pleasure to introduce our second speaker, Dr. Javid Moslehi, who is an Associate Professor of Medicine at Vanderbilt School of Medicine. He directs the Cardio-Oncology program, which is a clinical and research program focused on cardiovascular health of cancer patients. Dr. Moslehi's clinical and research interests include mechanisms of cardiovascular toxicities with cancer therapeutics, as well as adverse effects of tumors on the cardiovascular and metabolic systems. Please welcome Dr. Moslehi.
Thank you very much, Dr. Sun, and it's really a pleasure to be here. I just want to take a quick step back and say I'm actually a clinical cardiologist, and although for the last 10 years or so I've been focused on the cardiovascular care of cancer patients, I also run a basic science lab where we try to understand better the cardiovascular issues that arise in cancer patients. And I think that has been particularly helpful in terms of us better understanding the cardiovascular issues that arise from immunotherapies. So again, I just want to take a kind of a big picture view here. I think a lot about how the cardiovascular system and oncology intersect. It's from a review I wrote a few years ago. And I just want to make sure everybody understands cancer patients can have a lot of cardiovascular issues. There is intersection of oncology and cardiovascular medicine because of, in occasional cases, cancers themselves can cause cardiovascular disease. We see this in the myeloma population who may have amyloid, who may have cardiovascular issues as a result of the cancer itself. But this field has really blossomed in the cardiovascular space due to all the great work you oncologists have done in terms of transforming oncology care. And for the first time now, we look at a cancer patients, and if they have high blood pressure, if they have blockages in the arteries, it's a real issue because that patient in many cases is expected to live and they can do well. And so because of the explosion of number of therapies, we're seeing a lot of new diverse cardiovascular issues that can arise in cancer patients. And this, for the most part, has really seen in the cardiovascular space an explosion of cardiovascular physicians who are interested in care for oncology patients. And I think as we delve into this, literally every 6 months something new comes about. Now, the idea that cancer drugs can cause cardiovascular issues is not anything new. We knew 50, 60 years ago that if you gave little kids anthracyclines or you irradiated the entire chest, they grow up to be 25 and 30 and have heart attacks and have heart failure. And everybody in this room knows that 25 and 30-year-olds are not supposed to have heart failure or heart attacks. And so we knew about cardiovascular issues with these older traditional therapies for many years. And in fact, this has been a thing that we still think about with anthracyclines and radiation specifically. But if you think about this for a minute, both anthracyclines or radiations are essentially poisons we're giving patients, or we are giving patients. And they're very non-specific drugs in terms of how they work. What has been more surprising, however, have been the advent of newer therapies which are targeted, where we still see cardiovascular issues. If you're a breast cancer patient and you get any number of HER2 inhibitors, trastuzumab, pertuzumab, and whatnot, you're at risk of developing cardiomyopathy, which is why every breast oncologist across the country, for many patients, orders regular monitoring of the heart during the year-long therapy with, say, trastuzumab. If you're a kidney cancer doctor and you put your patients on VEGF inhibitors, most of you know that the blood pressure can go up within a week or two after starting therapy, and that patient may have a high risk of vascular disease. And we've seen this, unfortunately, with CML, whereas Gleevec, imatinib, the first drug used for CML, was a fairly safe drug. Some of the second generation and third generation drugs have had significant cardiovascular issues. In fact, the most potent BCR-ABL inhibitor, ponatinib, was transiently removed from the market because of significant cardiovascular issues. Now, the truth is, this is something that we knew about for the last decade. In fact, one of the interests I had is why these targeted therapies cause cardiovascular issues. But what's really changed are the number of newer therapies which cause a lot of diverse cardiovascular toxicities. We're no longer dealing with just heart failure, where the squeeze of the heart stops squeezing well. It's a defect in the heart muscle. We're seeing metabolic issues when the sugars go high. We see hypertension. If you're a prostate cancer patient now getting possibly dual androgen deprivation therapy, your blood pressure can go up, you lose muscle, you gain fat, your lipids change, all of which have adverse cardiovascular issues. We see this not just with kinase inhibitors, which is on the right here, but with drugs that modulate the proteasome. If you're a myeloma doctor, you know that if you start somebody on carfilzomib, a proteasome inhibitor, or give them lenalidomide, they have a high risk of thrombosis. And so these are the kinds of things that we think about. And then so I started a clinic about 10 years ago seeing cancer patients who have cardiovascular issues. And I moved to Vanderbilt about 4 years ago. And again, the issue is we see something new every day. And this came about a few years ago when we were started seeing patients with immune checkpoint inhibitors who have cardiovascular issues. Dr. Gady Mays did a great job of going over what these drugs are, so I'm going to skip through these couple of slides. I think one thing to note is, and this is a review that one of my students actually just put together, are the new indications for the many immune checkpoint inhibitors that have been approved, 7 actually that have been approved. But I think the other thing for us to think about is PD-1 inhibitors or CTLA-4 inhibitors represent a small fraction of the number of checkpoints that are out there. And you are going to be seeing a lot of new checkpoint inhibitors being approved, LAG-3 antibodies, which are going to be now combined with PD-1 inhibitors. And I think what's changed in the last few years is the advent of combination therapy. Either you combine different immunotherapies together, or you combine immunotherapies with existing therapies that themselves may have cardiovascular issues. And I think that's one thing for us to think about as this field really moves forward. Not surprisingly, as Dr. Gady Mays again very nicely said, we see a number of immunotherapy-related toxicities. But what's different about cardiovascular issues is the severity of symptoms sometimes, and how hard it is many times to actually diagnose myocarditis or other cardiovascular issues that may arise in patients. So let's start with a case here. This is one of the first cases we saw at Vanderbilt. It's a 65-year-old female who had metastatic melanoma, had metastases that went to the lung, liver, brain, and adrenals, and received ipilimumab and nivolumab, and literally 12 days later showed up with chest pain and shortness of breath, which admittedly are fairly vague symptoms, right? Chest pain and shortness of breath could be about anything. The patient presented to the emergency room, and if you ever walk into an emergency room in the US, you get a troponin check. I don't care what you come in with. Everybody checks a troponin check. And so in this case, if you cough, you get a troponin check. Troponin, of course, is a marker of myocardial damage, and in this case, this was very high, 24. It's actually very high. And so the patient clearly had some cardiac issues that we had to deal with. Again, I want to just take a step back and say, if you have a troponin increase, or you have an EKG change, which I'm about to show you in this patient, that could be, again, due to many causes. You could be having a heart attack. You could be having acute heart failure. You could be having any issues. So it doesn't mean that you have one specific diagnosis, and that just really broadens the differential in terms of what we as cardiologists think about. The interesting thing about this patient, and many cases we've seen since, is what happens with the electrocardiograms on these patients. These patients often have electrocardiographic instability. So in this case, you have this QRS version, which is the bottom of the heart beating, and there's almost no P wave tracking with the QRS, and so this patient is having a complete heart block. And it's almost an emergency in terms of how these patients can present. I don't have a good explanation for it, but for whatever reason, patients have a lot of arrhythmias with immune checkpoint inhibitors. Unfortunately, the next EKG is going to be a lot more obvious for virtually everybody in this room, This patient hasn't had an incessant VT, ventricular tachycardia, and died shortly afterwards. Again, this is, of course, not compatible with life. And because, but I want to also take a quick moment to pause here, because again, this patient could have still died to a number of different cardiovascular issues. He could have been having a massive heart attack for all we know. So we don't really know the diagnosis yet from how this patient has presented. Unfortunately, the patient again died, and what we could see on the autopsy in this case is evidence of a myocardial inflammation. This is classic myocarditis. And for those of you who don't look at hearts every day, this is what a normal heart's supposed to look like. And in this patient, there was a lot of white space, which is consistent with myocyte death. And you have all these little blue dots that should not be there. These are immune infiltrates that in this case had come into the heart. And this is, again, by definition, classic myocarditis. And so only after the patient died could be confirmed in this case that the patient had died because of myocarditis. Because again, up until this point, it could have been due to a number of different reasons. So we began to realize that this was an uncommon yet important complication to think about with immune checkpoint inhibitors, especially when you combine therapies. A number of my colleagues across the country have done very good work describing these cardiovascular toxicities that arise from patients. These are, again, I want to make sure rare, and although I think we think now they're more common than we initially thought, but unfortunately the problem is they're many times fatal. Now the interesting thing about oncology care, and this is coming again from a cardiologist, if you go to NCI and saw Dr. Gady Mays, you know you're going to have an expert seeing the patient. If you see Dr. Sun at City of Hope, you have an expert seeing the patient. Unfortunately, much of oncology care happens in the community in East Tennessee. And one of the things that we have realized, both with this issue, but many other cardiovascular issues that arise from cancer therapies, it's the community oncologist in East Tennessee who's giving CML, treating the CML patient, or giving the patient dual HER2 inhibitor for breast cancer. And many times there's not access to a cardio-oncologist, let alone a cardio-oncologist, and certainly in many cases not even a cardiologist. So we did something completely outside the box, and with the help of a number of collaborators, we started a website where, among other things, we try to interact with the oncology, our oncology colleagues in the community especially, trying to see issues if they arise in patients. This has been helpful in terms of our ability to help them, but also in terms of, as a cardiologist, trying to understand a new syndrome that didn't previously exist and was not explained before. We can gather information about these patients to better understand who's at risk. And I think this is sort of multidisciplinary, certainly multi-institutional, and teamwork is going to be critical as we understand these rare issues, uncommon, I would say, toxicities that can arise in patients. So initially, in a New England Journal of Medicine, we described this initial syndrome initially, but over the last year, we've begun to understand better what the immune checkpoint inhibitor-associated myocarditis entails. We realize now that many of these patients with myocarditis, the myocarditis, when fulminant, occurs relatively early after initial exposure to therapy. The median time from the initial exposure to therapy is 25 to 30 days, meaning most patients with fulminant myocarditis get 1 or 2 doses only. And that's really important for us to think about if we think about how to screen for this. Unfortunately, up until this point, we still see a lot of mortality. We see 50% mortality on this initial paper that we wrote about a year ago. As the numbers have expanded to over 500 now, that 50% mortality holds up. And we don't know necessarily why that is. In part, many of the patients can get steroids, but especially in the community, that can be a delay in terms of the diagnosis of this, or whether we have to think about alternatives other than steroids, and that's something also for us to think about. The main risk factor we have found is when you combine immunotherapies, or we combine immunotherapies with existing therapies. So if you combine ipilimumab and nivolumab, that portends about a 5 to 10-fold risk of developing myocarditis. And as best as we can tell, that's a main risk factor that we see consistently in terms of the patients who present with myocarditis. The patients can have concomitant myositis, which makes some sense if you think about how the muscle is similar in the heart and the skeletal muscle. But for reasons that are not clear to me, the patients also present many times with myasthenia gravis. And I have no explanation for this as a simple cardiologist up here. We published a paper in Lancet Oncology a few months ago using some statistical tools, using a larger database to look at the extent of cardiovascular issues. Again, I told you troponin increase and having EKG changes represent really, and that can represent many number of cardiovascular issues. But the consistent signals we see are patients not only can have myocarditis, but they have pericarditis, and they have vasculitis, which is equally tough to diagnose. And this signal of arrhythmias keeps coming up. As best as we can tell in this, and this is published work now, these patients are not necessarily having increased heart attacks, at least in the early going initial exposure to therapy. But these are the four, myocarditis, pericarditis, and vasculitis are the four consistent signals that seem to come up in terms of toxicities that you can see with immunotherapies. And if you think about this, this is a recent published work from our group. These are some of the cases that we have gathered. So for example, this patient died suddenly after getting a single-agent PD-1 inhibitor. And as you can see, the inflammation is really around one of the small arteries in the heart. And so this patient technically has vasculitis or arteritis, not myocarditis per se. We see cases of pericarditis. This is actually a patient I saw recently in clinic who received immunotherapy in a neoadjuvant setting for prostate cancer and has this consistent pericarditis. That's the white thing here you see on this cardiac MRI, where there's inflammation around the sac of the heart. One of the unique things about our program, especially since I moved to Vanderbilt, it's important for us to think mechanistically about why these toxicities arise. I think we can do a lot of good work together from a clinical perspective, but I think at the end of the day, we have to think why these issues arise. And I want to stress the importance of taking a step back and having research in this area in a preclinical setting. So if we had a mouse model, for example, we can think about new treatments for these patients, and we've started doing this. So we've developed a drug-induced model of immunotherapy toxicity, and this is these mice are in different genetic backgrounds, and we literally in this case just give the drugs. And this is the mouse that gets, this is the heart again, and you see more of a pericarditis signal, but certainly a vasculitis signal. This is the mouse's kidney. This is the artery, and you see all these blue dots, which is inflammation around the kidneys. And so for the first time, we have models where we could potentially study why these issues arise. A more interesting model has come about in collaboration. This is work in collaboration with Jim Allison at MD Anderson, where we've made genetic knockouts of the immunotherapies and crossed them together. Again, going back to what I said with combination immunotherapies. So this is a CTLA-4 haploinsufficient mice crossed with a PD-1 knockout mice, and the mice die at about 80 to 100 days because of myocarditis. Not autoimmunity in general, but myocarditis. And these tell us at least that PD-1 signaling and CTLA-4 signaling surprisingly have important roles in cardiovascular biology that we didn't appreciate previously. So there's a lot of work we're doing, not just with respect to these toxicities, but how does PD-1 or CTLA-4 work in other cardiovascular systems? What happens with transplant rejection? Is there a role for PD-1? What happens with general myocarditis that we see in patients? Is there a role for PD-1 or PD-L1? And I can talk about the next hour about some of the work that we're doing in this space. But I think it's important for us to think about, and taking a step back, developing preclinical models, because then at the minimum, in a space of myocarditis associated with checkpoint inhibitors, where really we have no treatments, where 50% of the die, you can think about ways of potentially having a model where you look at new treatment strategies. In this case, the combination of the mouse models we have made suggests an important role for CTLA-4 in the heart. I don't know what the mechanism is, but it suggests CTLA-4, for whatever reason, especially when combined with PD-1, it plays an important role. And it turns out there is a CTLA-4 ligand. It's called the drug called abatacept. And it's a drug that is actually approved for rheumatoid arthritis, although as I found out, nobody actually uses this. And in this case, we use the mice to give abatacept to the mice, and we attenuate many of the cardiovascular pathology that we see in the mice itself. And so I think this is an important thing for us to, again, I don't know what the role of the specific mechanism of CTLA-4 in the heart is, but at least if you reverse it in this case, it seems to attenuate symptoms. Does this have any impact for our patients? And I'm going to say yes, it does. We started a Cardio-Oncology fellowship a few years ago. These are all cardiologists who work with me. Some have come from other countries. And I think one of the things that's great about this, especially people who come from abroad, is they have gone now back to their original countries. In this case, Joe Ali Salam, who's a superstar in the cardiovascular space, has gone back to Sorbonne and actually established one of the larger programs in Europe now in cardio-oncology. And he had gone back, and he literally finished a few months ago, went back to France, and he called me about this patient who presented after getting PD-1 inhibitor with myocarditis, myositis, and myasthenia gravis. So she was essentially paralyzed. And unfortunately, this is a busy slide, but again, just focusing on the troponin, the patient after getting several weeks after therapy had a troponin increase. The patient had classic myocarditis or myopericarditis as seen on this MRI, and had myositis as seen on the biopsy from the skeletal muscle that was done on this patient. The patient was also paralyzed and had a CK increase, again consistent with the myositis bit. He tried steroids, nothing happened. We have realized through this patient, but many other patients, that the half-life of nivolumab or pembro or ipilimumab are actually very long. So if you just stop treatment and if you give steroids, you have not really had any impact on the patient. The patient underwent a plasma exchange, and again, nothing happened. Not only did nothing happen, the patient starts having VTs, so this was sort of an emergency. And he reached out and gave abatacept to this patient, and the patient walked out of the hospital about a month later. And again, this is N of 1, but I think it's the kind of approach we may want to think about, especially as a community, in terms of seeing these rare events and having at least, and I understand SWOG is especially good for clinical trial work, and I think this is just bringing this as at least one way we can start thinking about how to best treat these patients. I want to make sure we, besides the work that we're doing in terms of basic science space, we're doing a lot of work trying to understand better why certain patients get myocarditis or pericarditis. And this is really critical because it's not everybody who gets myocarditis or pericarditis. It's a fraction. And can we get better at understanding who is at risk? And I want to just walk through a couple of, again, somewhat sciencey things for a minute. When we saw these patients initially, who unfortunately had passed away, they had T cells in 3 different tissues: skeletal muscle, heart, and the tumor itself. There were not T cells all around. So something about the skeletal muscle and the heart was making these T cells go to those specific tissues. And we did something called, and many of you know, if you have T cells, you can have many, many different types of T cells, because at any moment you're supposed to fight pathogen A versus pathogen B, and these are defined by the alpha-beta receptors on the T cells themselves. So we sequence these beta receptors or the alpha-beta receptors, determining the clonality and what the specific T cell was. So there are literally 500,000 different types of T cells that we found. Surprisingly, and you have T cells that are only specific to the heart itself, that's seen here, or the skeletal muscle. But interestingly, there are a lot of T cells that are common both to the heart and skeletal muscle. And that's really interesting, but it's not very surprising because the skeletal muscle and the heart are similar from an antigenic standpoint. What is surprising are if you compare the heart to the tumor, which in this case is melanoma, which should have nothing in common with the heart really, and those same T cell populations come about. In fact, these 2 T cells over here are identical to these 2 T cells here. If you talk to immunologists, there's a lot of different explanations for this, but one possible explanation is that there's something inherent with the tumor, in this case melanoma, that's cardiac-like, that is expressing a cardiac-specific antigen. And we've done RNA-seq on these tumors, and we see high expressions in this particular case, for example, of troponin, of myosin heavy chain, which are classically cardiac-specific genes and antigens. And I want to go through, again, these are preliminary data, and I think we have to do a lot of bigger numbers. We're not doing this, we're certainly intellectually curious about this, but we're not doing this because we have extra time on our hands. It's also important to think about this because the implication could be huge for the patient. The one thing every oncologist in this room has access to is the tumor itself. You sequence the tumor, you don't necessarily do RNA-seq on the tumor, but I'm telling you that in this particular case, it's possible that tumor was doing something that was cardiac-like. And if we can potentially look at the tumor, sequence it, or do RNA-seq or whatever, we may have a better shot of determining who's at risk of myocarditis in this case or who's not. Again, we need to do a lot more work on this, but these are the kinds of approaches that I think is important for us to think about. This was given to me by Jeff Sussman, who's now at Northwestern, and it's already out of date. These are all the different individual trials for immunotherapies and specifically checkpoint inhibitors. But I do think when I started this talk, I talked about all these other drugs that I worry about in terms of their effects on the heart. But as we have seen in the last just few months, these other drugs that each themselves have cardiovascular issues are not being combined and used with immunotherapies. Just last week, the FDA approved pembrolizumab with axitinib, which is a VEGF inhibitor, which causes hypertension, cardiomyopathy, and ischemia in patients. And I have no idea what the combination therapy may mean in terms of our patients in kidney cancer. About 2 months ago, the FDA, of course, approved a PD-L1 inhibitor for triple-negative breast cancer. And those patients, many of them have been exposed to anthracyclines, have received radiation. And again, I have no idea what the implications are in terms of cardiovascular toxicity. It becomes critically important in this case to think about the diagnosis. How do we diagnose myocarditis? And this is an upcoming paper coming out in Circulation where we and a number of other colleagues have talked to our many community physicians, many oncologists, in terms of how we should think about myocarditis. Because again, if you diagnose myocarditis, how you treat the patient with possibly steroids or abatacept or whatever is very different than if you have a troponin increase or EKG changes that's due to myocardial infarction, which could certainly happen in anybody. So you really have to diagnose this important diagnosis firmly, and we think about the combination of pathology, which includes in this case endomyocardial biopsy or even skeletal biopsy. Other imaging that we use in cardiology, such as cardiac MRI or even PET scans, in order to determine who has myocarditis or not. And this is again important also not just for the real world population, but with many of the clinical trials that are coming where they're combining therapies. How do you in a clinical trial population determine who had myocarditis? If you can adjudicate this well, you can then go back and maybe think about how to best predict who has toxicities. This is a recent work that we published in terms of how to best think about, should we do surveillance on patients? Should we do surveillance on all patients who get PD-1 inhibitors? I don't think so, actually. At this point, we think the combination therapy is combination immunotherapy with IPI, Nivo, and possibly VEGF inhibitor with PD-1 inhibitors are arguable risk factors for developing myocarditis. And so maybe in those populations, we should do something as simple as a baseline EKG and a troponin, and maybe we should do troponin checks weekly afterwards. Again, this is just a proposal, but should we be thinking about this? If we're going to re-challenge the patient, should we do surveillance on those patients? I would say absolutely. And I think these are the kinds of things we really need to understand better as a community to better help our patients. Margaret talked about this paper. It is a very nice work that my colleague Doug Johnson superhead that was published in JAMA Oncology a few months ago. And this looks at a number of different databases I've used, as well as 7 different institutions in the US, where we looked at fatalities that occur with immunotherapies. And Margaret alluded to this. But it turns out if you combine therapies, it's a reasonable number of patients who die. And they die soon after getting immunotherapy, especially when you combine the drugs, without you even know if the cancer drug worked itself. And I wanted everybody to pause for a minute, because I think the number one challenge in personalized medicine today is the fact that a patient can go to an oncologist. The oncologist can sit there and they can certainly say they would not really have an idea which 30% will respond and which 70% will not respond. But I think the other issue that's often not talked about is which 1% is going to die within the 30 days after getting the especially combination immunotherapy without even finding out if they responded to the drug. And so I think this is an issue that we don't talk about enough. And I think we have to be better at diagnosing and treating these patients. I think we definitely have to think about more basic biology that I kind of alluded to earlier in the talk. But I think the other important issue is thinking about how to best care for these patients. I'm a cardiologist. I'm reasonably good at looking at an EKG and telling you if it's abnormal. I'm reasonably good at looking at an echo and telling you if it's abnormal or not. And I'm certainly reasonably good at telling you if a patient with chest pain has cardiovascular issues. I have no idea as a cardiologist how to diagnose myasthenia gravis. In fact, my neuro exam has not gone beyond non-focal for the last decade or so. So I think it's really important for us to think about these issues from a multidisciplinary approach. Dr. Gaddy Mays went through a great case of a patient with hypophysitis. Certainly you can go to a tertiary care center and have some oncologist who's decent at diagnosing hypophysitis, but certainly that will not communicate to the general community where 90% of the drugs are being used. And so it's important for us, especially in the academic centers, to include rheumatologists who can bring a different perspective, endocrinologists who different perspective, and it really calls for a new approach in terms of how we diagnose and how we treat the patients. At Vanderbilt, at least, every oncology fellow who starts has a didactic. The number one didactic in July 1st is about how to deal with immunotherapy toxicities, because that's what our fellows are dealing with on oncology fellows when they're on call. And so it's really important to kind of, as we try to understand these complex toxicities better, especially on patients who have concomitant, say, myocarditis and myasthenia gravis, to have a multidisciplinary approach. And we and a number of different centers have started this. I think this really speaks to a multidisciplinary approach in terms of treating our patients. And I don't know how many minutes I have left. I don't have a clock here. How are we doing on time? 5 minutes, okay. I want to talk about one last issue, and I don't have any data necessarily to support this, but I think it's also important for us to think about long-term what's happening with our patients. The success of immunotherapies, because of the fact that we get this 21% IPI-treated patients who live 10 years later, or the 30-some patients who may get a combination therapy who live 5 years later. And for the first time, at least in metastatic melanoma, we have survivorship going in the same sentence as metastatic melanoma. And we have poster childs of this, right? Jimmy Carter, former US president, just turned 94, received single-agent PD-1 inhibitor at the age of 90 when he presented with metastatic melanoma that went to his brain. And as best as we know, that tumor is no longer there. So I think one of the things for us to think about is what's happening long-term to these patients, because we don't want this to hit us across the face a few years later. And we have seen examples of this where kids, again, who grow up to be older have cardiovascular issues. And I think we have to think about this in our patient population. There's actually quite a bit of preclinical data that suggests, for example, inhibition of PD-1 has significant role in terms of promoting atherosclerosis. And we have some basic models, again, supporting this. These are, again, only hypothesis generating, but I think now may be the time where we think about long-term what's happening in our patients. I have a unique perspective on this. I started thinking about this a few years ago when I wrote this editorial for the New England Journal of Medicine for breast cancer patients who get radiation. I also happen to be the only cardiologist who sits on the NCCN panel, and this is one of the things that we think about in the survivorship group. And I think this is critically important because cardiovascular issues are a major issue that we think about with our cancer population. Whether you're 10 years old and had cancer and you're now cured, or 74, cardiovascular issues is a big thing that we think about. And we are thinking about why this cancer population is at risk of cardiovascular issues. And certainly it can be due to the toxicities of the very therapies that save people's lives. But we're also realizing that many common risk factors that we think of as classic cardiovascular risk factors are also important cancer risk factors. Dr. Cliff Hudis, a few years ago, as the president of ASCO, said obesity has replaced smoking as a #1 preventable risk for cancer. And obesity we always think of as a cardiovascular risk factor. We're realizing that hyperlipidemia is an important risk factor for certain types of cancers, for example, ER-positive breast cancer. And there's, I think many of you know of the potential, the importance of genetics in terms of determining risk factor for both malignancies and cancer. My former colleague at the Dana-Farber, Ben Ebert, had a phenomenal paper where you do mutations in the blood in a condition that he called clonal hematopoiesis, or CHIP, is not only an important risk factor for developing hematological malignancies, but these patients actually die because of cardiovascular disease. And I think it's really important for us to think about these common risk factors because it has huge public health implications. One of the things that we'll be rolling out at the NCCN over the next year is this idea of ABCDE approach to all of our cancer survivors, where we treat the cigarette smoking and cholesterol, we treat diabetes, we think about the dose of the medications. And I think we think the data exists significantly that we decrease the cardiovascular risk for these patients. But if these same risk factors are also important risk factors for a breast cancer survivor in terms of recurrence of breast cancer, if we attenuate these risk factors, it's a huge public health implication in terms of not only making their heart safer, but also decreasing possibly the risk of cancer recurrence in these patients. We have 17 million Americans now, that's 5% of the population who are cancer survivors, and that number will only increase over the next few years. I want to thank a lot of people here. This has really been a multidisciplinary effort. Some of the unpublished work with Jim Allison at MD Anderson, and a number of colleagues both nationally and internationally. These are actually our fellows. Again, at least in cardiology, this has become a very interesting topic for where the fellows who are already cardiology trained further work and do get cardio-oncology training. Thank you.
Thank you very much for that wonderful cutting edge presentation. So many answers, so many questions that we need to answer in terms of cardiotoxicity for our population.